Hi, I'm Lori. This is GLP-1 Journey in Review. Today we're doing a video in my interview series where we talk to people about their weight loss journey. Today we have with us uh, an obesity doctor who is going to hopefully answer a lot of your questions. I want to remind everybody that I am not a healthcare provider. My guest is, but she is not your healthcare provider. So please keep that in mind. I want to let everybody know that I have lost 70 pounds on my journey using compounded Tirzepatide. If you are planning on having a weight loss journey, I strongly advise that you seek your healthcare provider. If you find this information useful, please like and subscribe. Hit that hype button. It doesn't cost you anything. With all that being said, Doctor, why don't you introduce yourself?
Thank you so much, Lori. Thanks for having me. My name is Dr. Lindsay Ogle. I'm board certified in family medicine and obesity medicine physician. And I prescribe GLP-1 medications very commonly, both for type 2 diabetes and metabolic conditions, obstructive sleep apnea, and obesity. So I have regular practice in this, and I really love educating the public. Like you said, this is not direct medical advice, but I do think that sharing my knowledge and my experience is helpful, so I try to do it as much as possible. So thank you for giving me your
Well,
platform
thank
today.
you. So let's start with the very basics. What is obesity? Is it actually a disease? Is it just metabolic health? Explain that to us, please.
Yeah. So obesity is a chronic multifactorial disease. It was in 2013, I believe, that um, it was officially declared a disease. And it fits that criteria because there is underlying pathological changes that are occurring that lead to tissue dysfunction, so adipose tissue dysfunction. And what that means is that the fat cells in our body are active and they're releasing hormones and inflammatory markers that cause complications and symptoms for patients. And so it fits that criteria as far as I mentioned the multifactorial condition or part of it as well. So there's genetic causes, there's environmental causes like endocrine disruptors and
Mhm.
pollutants in the environment. There's lifestyle factors. There are factors that we're not even fully aware of at this time, and we're learning more and more. As far as treatment goes, like many of our chronic medical conditions, there are um, multiple treatment options that range from some lifestyle modifications, medication, and surgery. And most people end up doing a combination of those,
Mhm.
and that can be combined or added on over time. And treatment has to be long term to manage the condition.
Now, over my most of my adult life, doctors have been telling me that this is my fault. Is that true?
No, it is not true. And unfortunately, many people have been told that by healthcare providers, by the media, by family members, by coworkers, just everywhere. And that is really just a lack of knowledge, a lack of education, and weight bias, unfortunately. But that is not true.
Well, I know for myself, I tried to get the GLP-1 medication from my primary care physician, who is no longer my primary care physician because his answer was, you know, just eat less, work harder. And I saw a couple of others until I found one that honestly said, I don't know too much about GLP-1 medications. I'm okay with following everything else, and you go to somebody else for your GLP-1 medication and just keep me informed. Now, most people do go to their PCPs. Is there one thing that you would like PCPs to be telling these patients when they're prescribing the GLP-1 that kind of slips through the cracks?
That's great. It's hard to narrow down to just one.
Excellent. Sure.
And
Thanks.
yeah, one of the first ones that came to mind was to encourage their patients to communicate how they're responding to the medication. And that is both with the positive impact, so with appetite control, food noise, increased fullness, and definitely the negative side effects, most commonly GI related nausea, constipation, upset stomach, acid reflux. And it's really important for patients to communicate that to whoever is prescribing their medication, because the dose titration really needs to be individualized. And for providers who are not experienced in prescribing GLP-1 medications, they often look at the instruction label or what was done
Hmm.
or recommended in studies, and that is every month to increase the dose till you get to the max dose. And in reality, that can cause a lot of patients to either not tolerate the medication and have to stop because they're pushed too quickly and are having negative side effects, or they're having too much of what we expect as the positive effects, and their appetite is way too suppressed. They can't eat very much, and then they're feeling really fatigued and losing weight too quickly, which causes a lot of other complications. So, my recommendation is always to individualize the dose and titration. And many people respond and don't need to go to the higher doses. Everyone is
Hmm.
is different. So that would be my number one recommendation.
Now, along with that, do you think that some people should be microdosing or go halfway between doses?
Yeah, I think that that can be a great tool. It's not, in my experience, something I've done a lot of. Although now, in the last couple of weeks, Lilly Direct now has their multi-dose pin where you can
Mm-hmm.
count the clicks and kind of more easily manipulate the dose of that medication just by how it's I guess, put together in its multi-dose pen. So I'm experimenting with that a little bit more with my patients. And for example, some people who have a lot of appetite suppression or side effects right after their injection for the first couple of days, but then it wears off later on. I have a few patients where we're going to try splitting their weekly dose into
Mm-hmm.
2 doses and doing it every about 4 days. And so I'm really excited to see how that is going to work for them. So, for example, instead of for Zepbound, the 5 milligram dose, they're doing, instead of doing that weekly, they're doing 2.5 milligrams every 4 days to kind of more even their dose over time. So, I think that definitely plays a role. And I've heard of many patients, including some of my own, where they felt like we'll use the 5 milligram dose of Zepbound again, where maybe they're tolerating it, but they are not getting enough of those positive benefits. But going up to the 7.5 maybe felt a little bit too strong. So having the ability to do doses in between, I don't see any problem with that.
Now, I have an idea of what the answer to this next question is going to be, but what's the one thing that patients tend to do wrong when they first get on a GLP-1 medication?
Hmm. I would say that they're so used to diet culture and the thinking restriction is better and losing weight fast is better. And so people are really excited to start a medication and to see those results right away. And from a physician standpoint, when I'm always thinking about health at the forefront, I get nervous when I see rapid weight loss because I'm worried that someone's not getting enough calories, enough nutrition.
That's
Um,
right.
yeah, yeah. So I often am having to, slow things down with my patients and slow the titration and make sure we're getting enough calories and protein and fiber and nutrients and water. And so it's that switch from the diet mentality to more of that idea of that chronic disease and focusing on long-term results rather than, as fast as possible results.
Absolutely. So, What do you do to encourage them to get more calories? Like, do you recommend like protein shakes or other, protein bar supplement type things?
Yeah, I think those can be great tools, and I don't have like a particular brand that I recommend because everyone has
Hmm.
different preferences for that, and so I encourage people to try different brands. But I definitely think, especially in the beginning, protein bars and powders or pre-made shakes can have a excellent role and utility because they're easy to just grab on the go, and it can give a lot of nutrition in a smaller package compared to like a full meal that maybe they're not able to tolerate. So definitely in the beginning, and then also along the way, because like I said, they're very easy to grab on the go. Many
Hmm.
people have very busy lives, and this is something that you can just keep at home, in the car, in the office, and just use for a quick snack if you're very hungry or a meal replacement if needed.
Now, these are also considered processed foods. Do you have any problem with them using this type of processed food because it's not ultra processed?
Yeah. No, I don't have a problem with it, and, there's a lot right now that, like, kind of demonizing processed foods, and I think, in an ideal world, we're having, fresh food all the time and,
Hmm.
in a truly ideal world, we're growing it or we know exactly where it's coming from, but that's not realistic in our current society for most people. And as you mentioned, there is a spectrum of processed foods, and so I think that it's helpful to utilize processed foods in a thoughtful way. And protein bars and shakes, for the most part, are helpful. Um, if somebody has any questions or concerns or are like deciding between different brands or wondering what to look for, bringing that up with their physician, especially if it's a obesity medicine physician or maybe like a lifestyle physician, or if you have access to a dietitian, they would be great resources to really help you navigate that world because there are so many brands out there and the marketing can be really confusing to navigate.
Now, I know for me and also people that I've talked to on my channel, we've kind of noticed that our cravings have changed rather than, the chips and stuff like that. We're craving a little bit healthier type of snacks. Is there any science to that, or is that just our diet mentalities, kicking in?
Yeah, there is some science to that, because the GLP-1 medications are affecting us at the brain level. So there are true like preference changes that are occurring. And I was just actually looking this up kind of in the opposite direction because I had a patient who recently started and she was having pretty strong food aversion. So I was looking to see if there was evidence for that, for like not wanting certain foods. And there is a lot of data for that. A lot of like fatty foods, fried foods, very heavily, added sugar foods that have a lot of
Mm.
added sugar in them. They are just not as palatable, as enjoyable, both at the brain level, like I mentioned, and they were also saying that like taste buds are changing. So
Mhm.
actually, when you are tasting it, in your mouth when you're having that food, and so you have a different experience with those foods. So it is real. It is not imagined. That's part of the medication.
Now, I'm going to talk about a disease, and we'll just call it ED,
Mhm.
which I'm sure everybody knows what it is. But what are the red flags? And if you had an ED, does that mean you can never take a GLP-1? Can GLP-1s cause you to have ED?
Mhm. I appreciate this question. It's really important. Initially, when I was studying obesity medicine, we were kind of cautioned against using either anti obesity medications or obesity management medications. Um, in this population of people who have had an ED in the past. But now it seems like that's kind of shifted. And I know for my patients, I definitely have utilized them, but it has to be intentional and it has to be monitored very closely. Most of my patients who fall into this category have previously or are currently working with a talk therapist and or a dietitian, and we are going very, very slowly again with this titration. The most common ED out there is binge eating disorder. So many of my patients do meet criteria for this, and GLP-1 medications and a few of our other medications like Contrave, Vyvanse, Phentermine, Qsymia, those medications may also help, but definitely the GLP-1 medications can help decrease the urges for binges and binge episodes. But again, this has to be monitored really closely, and you have to be working with somebody who you trust to be honest about how you're responding while on these medications, because it can cause complications. And I at least follow up with my patients at least monthly. If I'm concerned about them, maybe I'll follow up every 2 weeks, and that would probably be more likely for my patients with an ED. And I always ask about their nutrition, and you can kind of get hints if someone is being overly restrictive or and hopefully my patients are feel like they're in a spot where they can bring up these concerns safely and be honest about those eating patterns. And when appropriate, we may need to place a hold on definitely titrating the medication or taking a break from it, and going back to our other resources like a dietitian and or a therapist. But so I think there's a role. It just has to be done thoughtfully.
Now, also, they're trying to take the unalive warning off of the
Mhm.
um, GLP-1 label.
Mhm.
Do you have any feelings about this? I know I personally have some mixed feelings.
Mhm. Yeah, I mean, I think mood, depression, anxiety, and any mental health condition is something that we have to take very seriously, and should be screened for before starting really any treatment, and following up closely. Um, in my practice, I've seen occasionally where it does seem like the GLP-1 is having a direct impact on mood. It's definitely not as common as some of our other side effects, but it can happen. And again, it just highlights the importance of working with somebody who you can have an open and honest conversation with and share that feedback. Um, but my understanding of the relationship with unaliving is that um, it's not necessarily a direct impact from the GLP-1. Many people, again, because of diet culture, believe that once you reach a certain body size, that everything in your life is going to be better. And the truth is that that's not the case. And that can be really upsetting when you've worked so hard for years and decades to reach this point, and then you do, and then you're not feeling mentally better. That can be devastating and can then trigger certain feelings. So that's where working with a therapist along in this journey can be so important. So that's kind of my experience, my thought, and
Mhm.
my understanding of the association.
So, who should not take a GLP-1 medication?
So there's not that many people that absolutely cannot take a GLP-1 medication. Really, the main contraindication is a personal or family history of medullary thyroid cancer or MEN syndrome, which is very, very rare. And that is a contraindication based on animal studies and not really, we don't think that that's true for humans to increase
Mm-hmm.
that medullary thyroid cancer risk, but out of abundance of caution, we would not prescribe it for those people. Other people we would be cautious with. We mentioned history of ED, so just being cautious there. If you're on insulin or sulfonylureas, diabetes medications that will acutely or rapidly lower your blood sugar, you can still be on a GLP-1. You just need to work with your doctor to adjust those medications and monitor your blood sugar closely. The like two other things that people often think of are gallbladder disease and history of pancreatitis. Those are not absolute contraindications. If you have active disease, then that's probably not a good time to start this medication. But if you have appropriate guidance and you're staying very well hydrated and again getting good nutrition in, then those are things that should not be a major issue. Kind of same thing with GI conditions like a history of gastroparesis or inflammatory bowel disease or irritable bowel disease. Those sorts of things just need to be very closely monitored if and when starting a GLP-1 medication.
If you were, okay.
Oh, sorry. Pregnancy, pregnancy and breastfeeding. Pregnancy, as of right now, we don't know that it is safe. So it is recommended if you're planning a pregnancy, stop 2 months, 2 or 3 months ahead of time, but stopping as soon as you become pregnant if you were not planning a pregnancy. And then breastfeeding, signs are pointing towards it's probably safe, especially for semaglutide. There's some early studies there, but right now, most people do not take GLP-1s when they're breastfeeding.
Along those lines, what about all these Ozempic babies that, is there any truth that it increases your fertility?
So yeah, I would say indirectly. So many women have PCOS, polycystic ovarian syndrome, whether they have that diagnosis and they know it or they don't. Different estimates range anywhere from like 1 in 10 to 1 in 5 women have PCOS. So it's very, very common. And it can decrease fertility. And one of the ways to improve PCOS symptoms is to treat the underlying insulin resistance and with weight loss. And so when you're on a GLP-1, you're treating the insulin resistance and you're losing weight, then that can lead to regular menstrual cycles and increased fertility. So there are definitely women who have either been told that they're never going to be able to conceive or they've gone years without using birth control because they haven't been able to conceive, and then they start a GLP-1 medication, then become pregnant. So yes, that is something that can occur. And so if you do not want to become pregnant, then definitely talk to your doctor about an effective birth control option. On those lines, for anyone who is on Tirzepatide and you're taking an oral birth control, the Tirzepatide specifically may decrease your absorption and the effectiveness of the oral birth control. So it's recommended to have a backup form of contraception for the first 4 weeks when you start Tirzepatide, and then every 4 weeks after, increasing the dose. But after that 4 week period, then it should be effective. But for Tirzepatide, we need to be a little bit more cautious with oral birth control.
Well, along the same lines, as PCOS, they're doing studies on Alzheimer's, Parkinson's, MASH. Are any of these findings surprising to you?
No, no, I wouldn't say so. As an obesity medicine, trained physician, I would say that's why I went into obesity medicine. I was exposed to the field when I was doing my family medicine training, and I guess even taking a step back, I went into family medicine to help my patients achieve and maintain their health and focus on preventative health care. And then when I was exposed to obesity medicine and saw that those patients who were getting that focused care were improving their chronic conditions and getting better compared to many typical clinics where chronic disease was more being managed and kind of slowing the progression. In obesity medicine, I was
Mhm.
seeing reversal of conditions. So I saw that, and then learning the underlying mechanisms that adipose tissue dysfunction that I mentioned, when that gets controlled, then all of these other conditions, there's like over 200 medical conditions that can be linked
Mhm.
to obesity, including different types of cancers, yeah, metabolic conditions. So treating the underlying cause of that adipose tissue dysfunction and often insulin resistance along with that, we can see improvement in all of these other diseases. And so I am just passionate about it and excited about it because instead of treating all of those individual things, as one, we can then treat that underlying cause with potentially one medication, or having that be the primary medicine, and then seeing all of those related benefits down the line. So I am not surprised.
Now, if you were on some sort of board that could actually change the way that we treat obesity or think about obesity, what would be the things that you would push for in obesity treatment?
Yeah, I think it would be some of the things that we talked about. Just continuing to spread awareness and education that obesity is a chronic medical condition and it's not um, a moral failure, or people are not not trying, and that treatment needs to be long term, because even though these are things that we know, the broad population does not understand that, and so there's a lot of work to be done there. So I think just continuing the education for the general public is one of the most important things, and thinking long term. So for coverage, the argument is that the medications are expensive and insurance doesn't want to pay for that for many of their patients. But really, if we have that investment now, then we're going to prevent, like we talked about, so many different
Mhm.
complications down the line and save money long term.
Now, what is your opinion on people that are using this medication because they've just got that stubborn 15 pounds, or people like Serena Williams that just couldn't get, rid of, the fat after she had a child. My brother, for instance, like I said, he just had that 12 pounds he's been trying to get off for like the last year and a half. So finally went on a GLP-1 medication, but we're never obese and are just using it until the weight comes off and then gonna see what happens.
Yeah. So I I think it can give the medications a bad rep, because people, I think that that can be for a lot of people prominent, what they see. I have this conversation with my younger sister, and we're both on social media. She's not in the medical field, and this is my specialty. So as you know, your feed is curated to what you're looking at. And so I see, so many people who are have their lives are changed because of this medication, and they're having all of these health benefits. And that's what I see in my practice. And she has more of a typical, early 30s female feed where she's seeing a lot of people like you described who are trying to lose
Mhm.
10 pounds, just so, they look better in a swimming suit, or for an event or something like that, and that has a clearly negative impact on people even seeing that, because again, that's diet culture. That's not obesity medicine. That's not what these medications are made for. These medications are to treat that underlying pathophysiology, that we talked about. So I never prescribe medications in that way. I don't recommend it. And whenever we're prescribing a medication, we're thinking about the risks and the benefits. And although I do think these medications overall are very safe, it's probably not worth somebody taking it for that reason. Um, and then On the other hand, I will also want to say that those people, like I think I kind of did mention it, that they don't have the disease of obesity, and so they if they do use the medication in that way, then they may be able to come off of it and do very well. And then I also think then they may share that story, and then that further confuses the picture because then the narrative could be, oh, well, I used it and it was effective for me and I was able to come off of it and maintain my weight. Whereas somebody who truly has the disease of obesity, that is a lot less likely to happen, and so that can then perpetuate those negative, that negative weight bias that, maybe that person is not the person who actually has obesity is not trying hard enough, or they're not sticking to, those changes that they made
Mhm.
after they got off the medication because they regain the weight, which is what someone like myself, an obesity medicine physician, would expect because that person actually has obesity. And when you take away the treatment, the disease comes back. So I think it's very confusing to the public when it's used in that way. And I don't endorse it.
Just to bring up a different point, like my cardiologist, who doesn't really have any weight to lose, is on Ozempic, but he says he's taking it for the cardiovascular effects of it.
Mhm.
And my brother, which I mentioned, also found that he really, used to have his, 2 to 3 nightly cocktails, just can't have more than like one cocktail a week on it.
Mhm.
So, there are other benefits that they
Mhm.
are receiving.
Yes, yes, absolutely. And then also to highlight that you can't tell somebody's health by just looking at them.
Hmm.
So there are definitely people who have a quote unquote normal BMI or normal weight that still have metabolic dysfunction or maybe at higher risk for cardiovascular disease. And these medications can help for those conditions. And so it doesn't mean that if you don't have obesity by, weight standards that you can't take these medications. Um, I guess what I was referring to then would be taking it just for weight solely.
Like the celebrity type of,
Correct.
to get into that role. So let's talk a little bit about the new Wegovy pill. It just came out. How are our patients asking for it?
Yeah, a lot of patients were interested in it. But then after talking about it, I have yet to prescribe it. And the reason being is that you have to take it in a very particular way for your body to actually absorb it and for it to be effective. So you have to take it on an empty stomach with a small amount of water, the least amount of water the better, and you cannot eat or drink or take any other medications for a half an hour afterwards. So for somebody who again has doesn't have a lot of time in the morning, maybe they're on other medications, it's not the easiest to incorporate to a daily routine. Um, so for that reason, a lot of people have, especially if they were already on a GLP-1, they choose to stick with that because a weekly injection is a little bit easier. But there can be people who this is a really good option for.
What about Orforglipron, which should be coming out soon, which doesn't have those restrictions?
Yes, I'm excited about that medication for that reason because it doesn't have those tight restrictions with taking it. There's a little bit less of an average body weight loss with that medication, but I think could be very beneficial for people, especially if they're needle averse. This could be a great option.
I know for me in maintenance, I'm looking at because I don't care about the weight loss. I just want to stay even.
Mhm,
And not that I mind the injection, but I'm just wondering if taking a pill 7 days a week might be a little bit more even than, I could tell the day before my shot, that my hunger is increased a bit and so forth.
mhm. Yeah, that's a great example of, kind of evening out your dose throughout the week, or a good reason to potentially switch, and especially in maintenance, I think that could be a really good option.
Let's talk about maintenance. Do you uh, Obviously, you have your patients still on a dose. Do you have them reduce the dose? Is it so individual?
Mhm.
Some spread it out, some just stay on the same. I know myself when I reached it, I wanted to lower my dose because I knew I had to eat a little bit more calories to
Mhm.
maintain. I wanted to stop losing. I didn't really like the idea of spreading it out because I know I take my shot on Saturday and that's it. I don't want to have to think about what day am I going to take it on and so forth. And I had to play around till I got it right.
Yeah.
How do you handle maintenance?
You're right. It is individualized, and unfortunately, we do have to take into account insurance coverage or cost. So that does play a factor when deciding what we're going to do. Um, for kind of my approach is that once we get to maintenance, we'll probably stay at that dose for a period of time, and while we're having the discussion of what how we're going to approach it. Um, if someone has insurance coverage and they're tolerating it and they're not continuing to lose weight once they reach their goal, then we can continue on that dose. That's not a problem. If they are maybe losing past what they feel comfortable at or what we determine to be their goal, then that's when we can maybe start to kind of take a step down, one dose at a time, and just watch how they're responding to it. But I would take kind of like that backwards step
Hmm.
down on their dose. And typically, for most people, I also don't space out their dose until we get to the lowest dose, because I do worry that if we're spacing out one of the higher doses, then it potentially could lead to more side effects when you do take your medication, because most of that is wearing out before you take your next dose. So I usually don't space it out until we get to that initial dose. And also, like you said, it can be harder to stay on top of when
Hmm.
you're due for your injection. So I always recommend like calendar reminders either on your phone or on a physical calendar of when you would have your next injection, so you don't lose track of that, because that can cause issues. So yeah, it's a very individualized approach, but definitely you want to titrate and then monitor somebody's response. Um, if somebody truly cannot, if they don't have GLP-1 coverage and they cannot afford to continue to pay out of pocket, however they're getting their medication, then I also consider some of our alternative medications that are available that maybe they haven't tried before, or if they did, it was not as effective to help them to reach that goal, but maybe it is effective enough to help with maintenance. So that's another thing to consider, switching to some of those alternative medications: phentermine, Qsymia, Contrave, metformin, and or a combination of those
Hmm.
medications. And then we always talk about things that we're doing to support maintenance. So physical activity is huge here. On average, people who are maintaining their weight are exercising for an hour a day, which sounds like a lot, but walking counts with that. And it doesn't have to be exact, but on average, an hour a day. They eat breakfast. So I'm a big proponent of breakfast, and people who maintain their weight are typically eating breakfast. They are not watching a lot of TV, so that again supports a lot of more physical activity. And then they are following some sort of nutrition plan, and that can look different from everybody, but kind of staying on track of your nutrition, whether that's with your physician or a dietitian or a coach, or however you like to do it. Staying on top of that is also important during that maintenance phase.
I don't know if it's just a fad or what, but it seems like everybody's like adding NAD plus
Mhm.
or B12, the fat shot, all sorts of peptides. What's your opinion on that?
As of right now, I think it's probably more a fad, in that just even the term peptide is so popular in like high search engine optimization SEO. And so a lot of companies, I think, are benefiting from that financially.
Hmm.
That being said, think that, some people have said that they've noticed a difference in how they feel with those. But especially if you're already limited on finances, which most of us are, it's probably not worth your money at this point, especially if you're deciding between that and your GLP-1 medication.
Well, let's talk a moment about insurance because most
Mhm,
people, insurance won't cover it.
mhm,
I know I'm on Medicare, and apparently it's against the law. A new program supposedly coming out.
mhm,
From what I'm hearing, it's going to be pretty hard to qualify on that. Who
mhm,
knows? Only time will tell. But, what is it going to take for these insurance companies to realize it's cheaper to give us the medication and stop these diseases than paying for my open heart surgery in 8 years, which I probably would end up needing because I have family history, a little bit higher calcium score than I would like.
mhm.
My cholesterol was high, which is, blood pressure was high, and now under control with the GLP-1. But they're not looking at long picture. They're only looking at short picture.
Yeah, which is so unfortunate. And I think that that's where getting these other FDA approvals for GLP-1 medications can be so beneficial. So I do have some patients who have Medicare right now, and they can't get Zepbound for the treatment of obesity, but can get it covered for obstructive sleep apnea if they have that, for example. So
Hmm.
the as we continue to see these benefits for these other medical conditions, then that'll help with coverage. It is really unfortunate because that just highlights the bias against obesity because we have this diagnosis, we have this medication that's so effective, but insurance won't cover it like it will cover with other indications. So that's where advocacy is so important. And the Obesity Action Coalition is one great organization that is doing everything they can to support legislation that will require insurance to cover
Hmm.
these medications for obesity. So I am hopeful that this will happen. It will, of course, take time. Um, but I think it's bringing back to education, advocacy, and research really will be the most important things. And people like yourself sharing your story is a huge part of that because it really um, personalizes what these medications can
Hmm.
do. And so, yeah, just keep doing what you're doing to share your story and get the message
Well, I
out there.
plan on it. Yeah. Now,
uh,
with the insurance companies, they're also, like with Caremark
mhm,
is like now only covering Wegovy, which kind of, lack of better terms, kind of screws the people that are on Zepbound.
mhm,
And now, from what I'm hearing, they're actually pushing for the oral Wegovy because it's cheaper.
mhm,
And I can only think it's going to also happen with the Orforglipron,
mhm.
as opposed to letting the doctors decide what's best.
Mhm. Yeah, and it's so frustrating because it just adds extra work all around. From our side, having to do prior authorizations and appeals, and it delays care for patients. And then insurance has to pay for those like prior authorization reviews and appeal reviews. And so it seems very backwards to add all of these hoops and layers to it because that adds cost. So I don't know. I wish it was different, and like I said, I am hopeful, but it is gonna take some time.
And now this is not a political channel at all, but not that long ago we had the most favorable nation where people thought, oh, we're finally going to start paying what other countries are paying. And sure enough, the drug companies decide, oh, we're not going to lower yours, we're going to raise theirs. So
Mm,
that was kind of a blow, to everybody. So, you know, people are really at a loss as to what to do.
I know, I know. Yeah, that is so unfortunate. It really is.
Now, what medication that's in the pipeline are you looking most forward to?
Mhm. Oh, that's a good question. I know I just did an interview with Dr. Marilyn Galindo, and we talked about the higher dose Wegovy,
Hmm.
Orforglipron. I'm still not good at saying that name yet. And then Cargisema, and all of those I'm excited about in general because it gives more options to people. The higher dose Wegovy, I have patients who do tolerate Wegovy well, and they're doing great. And I have some that are on the highest dose right now, the 2.4, and are tolerating it and kind of maintaining where they're at, but they have not yet reached their overall goal. And so being able to increase their dose potentially up to 7.2 milligrams is really exciting, because they're great candidates for that. Um, the Cargisema, that seems really, really interesting, a kind of a new mechanism to introduce. So for some people who maybe haven't either tolerated or maybe the current GLP-1 medications were not effective for them, adding in that amylin analog may be what they need to get some results. So having kind of a new mechanism is exciting. And then the Orforglipron, I don't know what that brand name will be yet, but like we talked about, that'll be a great oral option, help to lower costs, which could increase access. Is really great, or potentially for many patients like yourself or in maintenance, could be a wonderful option. And then potentially it will be in 2027, Retatrutide. That's, I think, what everyone is
Hmm.
really excited about, because it's showing amazing results. So that is, really wonderful to have on the horizon. I'm just overall excited to have multiple options to help my patients, again, individualize their treatment plans, and to improve access. And hopefully, with different brands competing against each other, that'll also continue to drive down the cost because many people are going to choose what is most affordable for them. So hopefully that encourages these manufacturers to keep the price down as well.
Yeah, I'm definitely, not an obesity medicine expert, but like I've been noticing that a lot of these studies for these newer medications tend to be more like, how it affects MASH, how it affects PCOS, sleep apnea. Are they doing this for insurance coverages? Like, oh no, this is really for MASH. It just coincidentally you lose a lot of weight, on.
Mm. That definitely could be the case. I never really thought about that, but that makes a lot of sense to hopefully get that FDA approval and then improve insurance coverage for it. Um, and so it would be strategic. And then I also think back to, potentially weight bias as well. But again, thinking about always, I mean, my approach is always keeping, health at focus. So being able to clearly show all of those improvements outside of just the number on the scale going down, I think is important, and further supports the importance of treating obesity as a disease because it's going to control and prevent all these other chronic conditions.
Now, we chatted a moment before this interview that I'm on compounded Tirzepatide, and you personally don't prescribe it. Understand it, but don't prescribe it. Now, I don't think there's a person alive that would not rather be on name brand if the price was a little bit more comparable. But one thing I have noticed is, this came out at basically 1200 to $1,400, and now 3 years later through Lilly Direct, I mean, you could basically get it for, four, five, $600 depending on the dose. I know in my lifetime I've never seen new medication go down in price that quickly. Uh, do you think it's because of the demand, the advocacy, or any particular reason?
Yeah, I think all of those. And with a program like Lilly Direct or for Wegovy, with Novo Care, the thought is that they're cutting out the pharmacy, cutting out one of the middleman, so saving some money there. Um, So I think that helps a little bit, although I think they do lower the price for that cash pay option. Um, and then, I mean, they want people to have their product as well. So if
Hmm.
insurance is not covering their medication, they still want people to have it, to have access to it. And so
Absolutely.
this is a way to achieve that. So I think it's a combination of all of those, including demand for the medication.
So Eli Lilly, Nova Nordisk, if you're listening, we're close. If you could just get it a little bit closer, I'd be more than happy to switch over to name brand, and I'm sure most people would. So, please listen to us.
Mhm.
Now I'm looking at my notes here. So, um, now, do you think the GLP-1 medication is going to take a chunk out of bariatric surgery, or is it a combined thing? Because I know I was actually close to needing bariatric surgery, and now I'm in a healthy weight range.
Mm. I think that it already has that. Many people who were considering surgery, tried the medication first. And so I do think those numbers are down. I don't know the exact percentage, but I don't think it'll overall take away the need for metabolic and bariatric surgery. Like I said, with the chronic disease model, a good analogy is osteoarthritis of the knees. So arthritis in the knee, like the wear and tear arthritis. Some people can control their osteoarthritis with physical therapy. So that's like the lifestyle side of weight
Hmm.
management. Some people need to take anti-inflammatory pain medication. So the medication side, the GLP-1s, and then some people do need a knee replacement to control their disease. And I think the same is true for the disease of obesity. So there always will be a role. Um, what I think can be really, really helpful is for patients who have a very high BMI and maybe a higher surgical risk, doing a GLP-1 medication first to get some of the weight down and potentially metabolic conditions under control will help prepare them for a safer surgery when it's time to get the surgery. And then potentially some people after their surgery may need to add on a medication. Usually, it's recommended to wait at least 1, ideally 2 years after your surgery before adding on a GLP-1 medication. But some people do need to add that on after a surgery to continue to control their disease.
Now, what is your opinion on GLP-1 in other industries? For example, Chipotle now has a high protein menu. Starbucks has a high protein menu, probably a little bit too much sugar than what it should have, but it shows it's trying. You can't go through the grocery store without seeing this GLP-1 friendly label on it and so forth. And even my gym has gotten rid of a little bit of their cardio and extended their weight training a little bit.
Mhm.
Is this because of the GLP-1, or what's your whole opinion on that?
Yeah, it seems like the market is responding to the demand and what people are looking for, which I think is great. And again, thinking about like the food packaging with processed foods, like I said, there is a role for processed foods, and sometimes we
Hmm.
want chips or something like that. And so if we can clearly see that one chip brand is maybe targeted towards GLP-1 users, I would still look at the label and look at the
Hmm.
ingredients, because marketing can be misleading. But I don't think there's anything wrong with having more products that have more protein and hopefully more fiber in it as well. Um, it, I think it can help steer people in the right direction.
Now, do you think people on GLP-1s are going a little too protein crazy? Like, I'll see, what I eat in a day. I had 185 grams of protein, like, do they really need all that protein or?
Probably not, and it depends on somebody's body size and their activity, but, yeah, it seems like the focus is solely on protein. I've been seeing a little bit more content online about fiber and the importance of fiber,
That
and
I was just going to ask you about the forgotten fiber part of
yes.
it and water. Yeah.
Yes. Oh my gosh, water. I still say that's the number one mistake that people make is they're not drinking enough water. And that leads to people just not feeling well and a lot of the side effects. So, yeah, let's not forget water and fiber as well.
Okay, so sorry, I'm just looking at my notes here. Uh, Okay, now, how big of a role is the resistance training versus just walking and so forth? Because, some people just, especially when they start out and they are obese, can't really do the resistance training. Is this something you should build into? I know I was lucky enough, I work in the medical profession, so like I have a little strange way of thinking anyhow, but I always worked out even though I was, obese, because just in case I needed an emergency surgery, I wanted that surgeon to go, oh, she's got a lot of fat, but she's got muscle under that fat, like, so I always worked out and, that wasn't a problem. But, I know people that, just can't do it until they're several months in.
Mhm. And I think that that's okay. There's so much emphasis on muscle mass loss on GLP-1 medications, and it's good to be aware of and do everything that we can to prevent that. And that includes eating enough, titrating the dose slow, getting enough protein, and exercise and physical activity. And that includes cardiovascular activity and strength training. So everything you do and moving your body throughout the day, can be considered a form of strength training. And there's like just a spectrum of, more light to heavier. So even getting up and down out of the chair is considered strength training. So I always meet people where they're at. So if somebody is not exercising at all, it is very unrealistic to say to do that an hour a day for
Mhm.
5 to 7 days a week and getting 20, 30 minutes of strength training 2 or 3 times a week. That's our goal, but we're not going to start there. We're going to add that on. And many people who are carrying extra weight, it's very hard on the body to start exercising. So we start with what we can, and that's different for everybody, and then build upon that. And when people are, living their lives and carrying extra weight, you're building muscle with just moving your body, and so you do have more muscle than what somebody at a smaller body size would have. And so it is okay to lose some muscle mass, and that's expected for most people when you lose weight. But what we want to do is to try to keep your body functional. And we need to just assess, are you still able to do the things that you need to do to move your body in space, and do you have energy and strength to complete the activities throughout the day? If the answer is yes, then don't be too hard on yourself. You're doing a good job, and then we can slowly increase that over time.
Now, people have mixed opinions on this next one of supplements. I know natural is always better, but some people say your supplements are just creating very expensive urine. Are there any supplements people should be taking? Are people going overboard on them?
Mhm. Yeah, people can spend a lot of money on supplements, a lot, and there's a lot of marketing that makes it seem like it's really important or that you're hurting your health by not taking a certain supplement. I definitely recommend targeted supplements. So, what are you trying to achieve with that supplement that you're taking? And if you can't answer that, then you probably don't need to be taking it. And if you have any questions, again, talking to your doctor and or dietitian to get their recommendation, I think is really, really helpful. Just in general, I mean, it doesn't hurt to take a multivitamin or like a prenatal vitamin. Um, like you mentioned, if you already have enough of vitamin C, for example, you're gonna just pee it out. Your kidneys are gonna filter that, so you're not gonna really do any harm with that. And they're not as expensive as some of the other supplements.
Hmm.
For certain vitamins, I think it can be worth getting tested for, like vitamin D, iron levels, B12, folic acid. And if you have other concerns in certain situations, we may check some other levels. But that can be beneficial to check because there can be like prescription strength supplementation for those that you may require, especially if you've had metabolic and bariatric surgery, or you have a GI condition that can decrease absorption. You need to get those levels actually checked and managed by a health professional. We talked about protein supplements, so that's considered a supplement and I think has a really good role for a lot of people. And then kind of along those lines, like collagen or creatine, those things could be considered, but another important strategy when using supplements is to start one at a time and give it at least a few weeks, if not a few months, and then you can assess if it hasn't made you feel better, have you noticed a difference in what you were trying to achieve? If not, then you probably don't need it. And if you did feel better, then you can continue it, and it's probably worth your money then.
Now, what's your opinion on gummy supplements, especially, gummy fiber? Like they have now like a bag of candy that's gummy, 70 calories and like 26 grams of fiber, which I know I tell people that if you're going to do that, don't do it all at one time.
Yes, exactly, especially when you're not used to eating a lot of fiber, that can cause a really upset stomach. Um, I guess I would say I'm not necessarily against them, but you're probably like for many of the gummies, if you're just like taking like the 2 or 3 or whatever is recommended, they usually have less amount of whatever that supplement is than what a capsule or a tablet or a powder would have. So just paying attention to that. And anytime you're doing a fiber supplement, bringing back the water, you have to have a lot of
Mhm.
water with it, or else it's going to do the opposite and cause constipation and cause a lot of stomach upset. So you have to drink water with any fiber supplement in particular. But the gummies, I mean, it can be a nice little treat, especially if you enjoy it, like the multivitamin, if that's how
Mm.
you want to take your multivitamin, and that's your little treat for the day, then I don't have anything against it. You just may not be absorbing as much as you would with a capsule or tablet.
So I tend to wrap these up with what is your best advice for somebody thinking of starting a GLP-1 medication?
Yeah. Um, I would Oh my gosh, I have so much advice. I initially, thought about what I said in the beginning with trying to work on changing your mindset from that diet culture, number on the scale focus to a health focus and long-term focus. And to do that, you typically have to work with somebody who is educated in this field, whether that is an obesity medicine physician, a dietitian, therapist, coach, somebody who is going to help you with that mindset shift. And it's something that takes time. It's not going to be like right after starting the medication. It's going to be over, multiple follow-up appointments. And then along that process, starting to think about what maintenance is going to look like and then prepare yourself for that, because that a lot of times is the hardest part, is the maintenance, because it's less exciting.
Mhm.
You're not getting, the compliments that you were getting before. The numbers aren't changing, both on the scale and like your health related numbers with labs and blood pressure and that sort of thing. It's just maintenance. It can be dull, but it can be challenging, but it's really, really important. And that's the ultimate goal. So again, yeah, switching from the diet mindset of those up and downs to health and maintenance long term.
Anything you want to bring up before we wrap this up?
Um, no, I thank you for giving me the opportunity to touch
Thank
on so
you.
many different topics. This was really great. I would say also just following platforms like this and getting a good community and having those positive inputs throughout the day, I think really makes a difference. So, yeah, so that would be my last thought.
All right, all that, and then this is a wrap.